Hello everybody, I'm Izzeddin Barakat. I'm one of the doctors currently working in the NHS in the FY2 standalone program, and this is my playlist on tips needed to pass Plab 2 exam. So make sure you are subscribed to my channel to get all of my videos, and stay tuned for a separate video on how to get accepted into the FY2 standalone program and be part of the foundation program in the UK. Let's jump into today's video. In the first 3 videos, we discussed how to establish rapport with the patient, how to discover the patient's concern, and how to manage your time in the station. Today, we will talk about the 4th tip or the 4th criteria that the GMC sets, upon which they mark your performance on the exam day, which is the diagnosis. And this is very important tip, and a lot of Plab 2 candidates make mistakes in it. Let's start with saying that there is a misconception between Plab 2 candidates, and I touched this personally in the mocks that I conducted throughout this year, that the candidates become afraid if they finish the station without knowing what's really going on with the patient, without telling them definitive diagnosis and definitive plan of management. And I have to say that this is wrong. This is not always right, or in other words, this is not always waited from you and expected from you in each station. So let's set a rule together that you are only required to tell a diagnosis if you have enough information from the patient, if you have enough examination findings, and if you have enough investigation results. Otherwise, it will be completely wrong to tell a definitive diagnosis, and you will appear so scripted if you did so. To make this idea clear, let's imagine this scenario together, and this is a realistic scenario and also can come in the exam. Imagine a young patient, a young female patient who presents to you with 1-day history of left iliac fossa pain and history of vaginal bleeding the day before. She is sexually active, she doesn't use any form of contraception, and she wants to know what's really going on with her. The wrong thing that you will say to her is that you need to get admitted to the hospital because you have ectopic pregnancy and we need to perform a surgery on you so that we can terminate this pregnancy, as it is unhealthy and it will be quite serious on your life. So why is this wrong? Wouldn't you suspect ectopic pregnancy in such patient with risk factors? I would, and everyone would, but you cannot say definitely and confidently that this lady has ectopic pregnancy without first performing a pregnancy test to establish that she is pregnant now, and second, do ultrasound to see that the womb, the uterus is empty and there is no pregnancy in it, and the pregnancy is elsewhere. So before performing those 2 investigations, you can never say to the patient that you have ectopic pregnancy. And there is big difference between telling the patient, I'm suspecting that you have this condition, and for this we need to do further investigations, and if confirmed we will do so and so. That's one thing, that's one story. And on the other side, to say you have ectopic pregnancy, we need to get you admitted to hospital to perform surgery and terminate this pregnancy. The first way is the right way to say it, because you don't really know at the moment you are speaking to the patient what's going on with her. And the second way is the wrong way, because you will appear that you know the station, you are scripted, you know that the lady that presents with left iliac fossa pain and vaginal bleeding has ectopic pregnancy, without really depending or building your diagnosis on the data that you gathered from the history and from the investigations. So, if we want to talk about the first step when telling a diagnosis, is that you are not always required to tell a diagnosis unless you have enough information to justify your diagnosis. The second tip which is related to the patient's concern that we discussed in a previous video. Imagine the same scenario that we said on that video. If a patient presented to you with a headache and you made your diagnosis that this patient is having tension headache, but you discovered in your questions that the patient was afraid of having a brain tumor. And then you have finished all of your data gathering and you are about to start talking to the patient, giving them information about what they have and what will be done to treat this condition. And you started your talking by saying, look, you have tension headache and that's how we are gonna treat it. That's also wrong. You are not wrong in the diagnosis itself, but you are wrong because this shouldn't be the first thing that comes out of your mouth if the patient has a concern. A much better way to do it is to answer the patient's concern first and then give them the diagnosis. So if their concern was about a brain tumor, it's very nice to say, look, from what you have told me and from the investigations done, if you have requested any, it doesn't look to me that you have a brain tumor because 1, 2, 3. And it looks like you have what we call tension headache, and start explaining it, start telling the patients how you are going to treat it. It's just the order of words makes big difference in the rapport with the patient, in the communication between you and him, and in being really patient-centered and targeted on what he said to you, what was really concerning him, not what you believe is important. For you, you enter every station having in your mind how I'm gonna transfer this symptom into a diagnosis, and that's your main aim, which is not the main thing that's going in the patient's mind. In the patient's mind, he has a question and he needs answer to it. So a balance between the two is really important. The third tip, which is important, which is common in real life and exam, how can you deal with a situation when you don't really know what's going on with the patient? If you have finished all of your questions, if you have done all of the examination, if you have requested all the possible investigations and you still don't know what's going on with the patient, what can you do? You don't even know what to suspect. What can you do? Let's say a patient is having a chronic cough for 3 months and he has done all the investigations and nothing came back positive. It needs further investigations. How are you going to deal with this? You need to put in your mind that this uncertainty is intended. It's not your fault. It's the way the station is designed. They want to see how you are going to deal in this situation when you don't really know the diagnosis. And my golden rule for this is that it's not a mistake at all. It's not a wrong thing at all to say, I don't know what's going on with you. We still need to do further investigations. I still need to discuss this with my senior. All of these things are the right things to do. But what's not forgiven, say I don't know when you didn't rule out any emergency cause of this symptom. So in short, if you are faced with a symptom that you don't really know what's causing it, all what you need to do, apart from the regular stuff, regular investigations, is to rule out the emergency cause, and you can always do. If a patient is presenting with chest pain, it can happen that you don't know what's going on with them. But it's not accepted at all that you miss a pneumothorax, you miss an MI, you miss a pulmonary embolism. You know how to rule out each one of them, and after ruling out all the emergency causes of each symptom, it is then accepted not to know what's going on with the patient. So that's it, guys, for today. Those were the common mistakes in the diagnosis and my top 3 tips on how to say a better diagnosis in the exam. Make sure you subscribe to my channel to get all of my videos and put a like on the video if you like my content. Stay tuned for my next videos and thank you for watching.